Welcome colleagues, welcome friends, welcome students to MuniMeterHealth, your source of learning cardiology and human heart. This is Dr. Jaitly, your cardiologist from New York. Welcome again on MuniMeterHealth, your source of learning. Very briefly, we're going to be talking about what are the possible drug therapies that are available for heart failure, or HF as known as in future. Well, there are several groups, but ACE and ARBs have been the longest. You remember that? Okay, amongst the ACE, now we have already discussed the mechanisms of the actions of these drugs. So just so that we save time in this short video, we'll enumerate the drugs and possible dosages and maybe the side effects. Okay, so ACE inhibitors, you start, the oldest one was capitan or captopril. Okay, the next one was enalapril or Vazotec, enalapril. And then subsequently came out fosinopril. We're not going to write the pills now anymore because they're all pills. And then came out the lisinopril. And then, of course, came out the quinapril and ramipril. Quinapril and then the ramipril. So these are at least you have at least a half a dozen of these ACE inhibitors in the market currently, which many of these patients are utilizing. And capitan, remember that this is 3 times a day drug. Okay, so you start with like a 25 TID and then titrate it up. Remember that the most trials that have shown a great deal of improvement in terms of their morbidity and mortality. Okay, we are talking about morbidity and as well as survival pattern, because that's one of the keys in heart failure. So all these trials, they've really shown when you have maximized on the ACEs, maximized on the ARBs, maximized on the beta blockers, maximized on the ARNI, of course. ARNI is a newer drug which we'll talk about. So remember that you start with 25 BID or TID rather, but you move it upwards, and that's the whole idea, wanting to see how best you can calculate. So now important things to really worry about here are, we'll just show it in a different color, the renal functions like I'm showing you here. So you have to do the KFTs. So renal functions are very important in these. So check for the K and check for BUN and creatinine, very important, and follow that. In enalapril, you can start with like a 2.5 milligrams dose and move it upwards, go to 5 or up to 10. And so on and so forth. Just remember, quinapril is a BID drug, and therefore it requires twice to be taken twice. Now, so these are various examples I've just given you. Now, ARBs here, you know, the 3 of them that really stand out in the ARBs are candesartan. Then you have losartan or Losar, and then you have valsartan. Okay, so they are artans. The artans ending in, they are all ARBs. Prils are all ending in, if they are ending in prils, then automatically they are the ACE inhibitors. So losartan, again, it's a QD drug. Remember, valsartan is a BID drug, so it requires at least to be given twice, because you need to, the dosages sort of wear off if you give it only on a QD basis. And losartan, you can start safely with a 25 and then go up to 50 twice a day or something. And that's pretty good. But again, follow the renal functions. The K and the KFTs are very important. You have to follow the BUN and creatinine and the potassium. Remember, both these drugs, they are potassium sparing drugs. So the potassium levels must be followed. Why? Because the potassium tend to go higher in these individuals. So do not give potassium with ACE or ARBs, because they are potassium sparing drugs. Another one which is another one that is potassium. Let's get this right. Potassium sparing drug is ACE, ARBs, and also what do you have? The mineralocorticoids. So these are potassium, and to an extent, of course, here you have to watch here as well in the ARNI group. So you know, they're all potassium sparing drugs. Now, we did not include, you notice that diuretics here, but we'll put that down at the end. That's only for patients who have volume overload. So, or if they have issues with potassium, then you can combine that with a diuretic, and certainly these are really to be used as and when required. So I call that PRN, normally for volume congestion, maybe in the lungs or in the, and again, diuretics, the classic examples are Lasix. Okay, and that's an age-old, almost for like 100 years, people have been using Lasix. Next you come to is the ARNI group, which is a very, very new group. Only it's been around for 2 or 3 years, and it has shown again prolongation of survival in heart failure patients. And there are landmark trials. You can just look for those. But ARNI is basically an angiotensin receptor neprilysin inhibitor. Angiotensin receptor neprilysin inhibitor. And the dosages that you normally start are 24, 26, 24 being the ARB, and the ARB here is valsartan. Losartan. Actually, it is valsartan. And here the 26 is your neprilysin inhibitor, which is sacubitril. So sacubitril. So valsartan, sacubitril. Valsartan is about 24 and 26. Don't ask me why, but that's how the combination is. And that can go up to 49, 51, or a higher dose, if you will, and that could be 97, 103. Tough to memorize them, but that's okay. You can just remember these. Beta blockers, the landmark trials were shown by metoprolol, and then subsequently with carvedilol or carvedilol. Now, carvedilol is an alpha and a beta blocker combination. Metoprolol is a pure beta 1 selective. And whereas carvedilol is beta as well as alpha both. So they have a vasodilating action as well, and of course a beta blocker action as well. So that's the beauty about this drug. It has a dual action. It's a dual action drug, I call it. So metoprolol you can safely start with 25 and then go to 50 milligrams up to 100 milligrams or even up to 200 milligrams. Again, the side effects are very, very clear with beta blockers. Remember, they drop the heart rate. They are negatively inotropic, so especially in a setting where you have an acute heart failure, try to avoid the beta blockers. Even if the patients are on beta blockers, you tend not to give them while they're on acute heart failure. So that's one of the and remember, they have peripheral vascular disease patients who have cramps or secondary, so these are contraindications: low heart rate, peripheral vascular disease, and of course acute heart failure. And there are other minor indications where people who have asthma, etc., they may react inadvertently because of the non-selective action, especially when you go in higher dosages. These beta blockers tend to become non-selective. Okay, otherwise they're beta 1 selective, so they will be only working on the cardiac beta receptors, not on the bronchial beta receptors. Remember, bronchial tree also has beta receptors there. IF channel is relatively new, so this one is new, I call it, and this one is new, I call it. So IF channel is ivabradine, or we call it ivabradine. That's a newer drug, and that is reserved for only patients who have heart rate more than 70 while they are on maximized beta blockers. So somebody who's on maximized beta blockers, say 50 BID already, or 50 QD of say metoprolol, and yet the heart rate is 70 and you can't give more because the pressure tends to drop or whatever else is happening. So at that point, IF channel drugs, ivabradine is a newer drug. Again, this has not been shown to improve the mortality. I'll go over that as soon as we hit the bottom of the list, which drugs are really good. MCA, which is the Mineralocorticoid Antagonist, there are 2 prototypes here. One is spironolactone, which is also called aldactone, Again, the trade name is aldactone. And they start with 25 QD per day to going up to almost 50 BID, or maybe, BID is a good dose. And then the other one is aprelenone, EP and LERENONE, eplerenone, and they also come in 50 milligrams is approximately the dose. Anyway, the spironolactone, again, this is potassium sparing. It works by blocking the aldosterone antagonist, so that's why they are aldosterone antagonists. We also call them as aldosterone antagonists. And these drugs they're age old. They were even before the ACE arrived, even before the beta blockers arrived. So I used to use them in my med school. I just told you my age. But the funny part is they were forgotten for like 20, 30 years till we could demonstrate as on some trials that there is a prolongation of survival in heart failure patients suddenly, and that was noted. And then aldosterone antagonist, the resurgence into the regimen for heart failure patients arrived. And this is how it all began. So anyway, so they're back into the armamentarium for the past 15, 20 years, and we tend to reserve these patients after somebody's already on ACE or ARBs or a combination, or they have been already on beta blockers, and the next step is to give them ARNI. And when you put them on ARNI, obviously make sure the ARBs are taken off, because you already have an ARB in there. It's called the valsartan, and the sacubitril is the other combination in the ARNI group. And last but not the least, vasodilators I tend to suggest, and they are isodil plus hydralazine. And isodil obviously comes in 10 TID or 20 TID, 30 TID, but again, remember there's a tolerance that can happen with these nitrates. Hydralazine is a powerful arterial dilator, so remember that. So again, here you start with 25 TID, and there's tachyphylaxis associated with that. But just mind you, vasodilators, this isodil hydralazine combination should not be used if there is no beta blocker. In other words, use it only after the beta blockers are on board. So remember, beta blockers should be on board first and then use these vasodilators. Otherwise, there will be reflex tachycardia and the heart rate may increase, and that may compromise the heart failure. It can also worsen your CAD. So it can worsen the CHF, the heart failure, and worsen the CAD if there was no beta blocker being used. So make sure beta blockers are always in place first, and then combine them with the vasodilators. Diuretics we've already discussed, and these are potassium sparing drugs. So remember, the potassium goes down, so that's why I'm putting as K negative. But others are all K positive here. Predominantly, beta blockers also tend to, to an extent, preserve potassium, but just as that's only on a board question. Very rarely somebody would ask, but just so that you know. Okay, so having defined all of this, now which drugs really prolong the survival? ACE, ARBs, ARNI, definitely, beta blockers, and aldosterone, this one. Hydralazine and isodil has been shown in African American population to improve. So I'll just say African American population. These populations, they tend to have a better survival rate in these individuals who are placed on isodil and hydralazine. And diuretics have not been shown to improve the survival, and neither the IF channel, the new drug, ivabradine. But they certainly contribute to the symptom improvement dramatically, but they have not been shown to improve the survival in our heart failure patients. Very shortly, I discussed this, so hope you enjoyed this magic screen here that I use to write, and hopefully this was interesting for you and a quick grasp on what are the drug therapies available for heart failure in various settings. Okay, looking forward to seeing you again on MuniMeterHealth. Come back and learn more with me. Thank you.